and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Providence. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for speakers throughout the webinar. And with that, I will turn it over to our moderator who joins us from Providence, Sarah Vaezi.
Thank you so much. Welcome, everyone. We're so excited to have this conversation today and to have all of you joining us. I'm also thrilled to be joined by four incredible colleagues who will be our panelists today, and momentarily I'll ask them to introduce themselves. Today we're going to be talking about engagement. This is a topic that's critical to growth for health systems, growth for, frankly, any industry. And what we are going to be talking about today is within the context of health systems and from an investment lens, what are we actually referring to? It's a word that's been used in many different forms and forums. Frankly, the definition is somewhat diluted by now. Apologies, very bad time for me to have a frog in my throat. So while we do some introductions, and while I get a little bit of water to drink, I'm going to ask our panelists to please introduce themselves and then just give your, Twitter length definition for what do you think engagement is, or what does it mean to you, and what isn't it, right? So let's try to get a little bit crisper around the definition as a framework for today's conversation. So let's start with Nick Reddy.
Thanks, Sarah. Good afternoon, everyone. I'm Nick from Baylor Scott & White. As background, I spent a dozen years in consulting, and I went native, and I joined my client 10 years ago, and I serve as our chief digital officer at Baylor Scott & White. And what that means is I have digital teams, product teams, analytics, and platform teams that I oversee. Sarah, to answer your question about what is patient engagement to me and what it's not, I think obviously patient engagement is an elusive desire for the industry. So I think it's trying to meet their needs at the moment is what I think about. Do you have the capability to meet their needs at that moment? What I think it's not, which is what I usually see, is a lot of what I call patient entrapment, which is doing something for patients just so that you can fill your referral channels or things of that nature. So I think we usually want entrapment and we call it engagement. So I think that's the way we challenge ourselves to see if it's engagement or entrapment internally. So thank you for having me.
Thank you for joining us, Nick. And since we saw each other last week, I've used the engagement, not entrapment line a couple times, and it's certainly resonating with folks. Welcome. Next, over to Lee Schwam.
Hi, everyone. Hi, Sarah and panelists. Nice to see all of you again. My name is Dr. Lee Schwam, and I lead at Mass General Brigham our efforts in digital patient experience and virtual care. I'm a stroke neurologist originally by training and have been in the field of digital health for 20 plus years, starting with telestroke and really going from there. I think engagement, to me, I love the engagement, not entrapment concept. To me, engagement is about an ongoing dialogue or embrace with our patients, that they think of us when they think of their health needs, and that what we're trying to do is be in a dialogue with them. Whether they're delighted with our care or have comments about how they'd like us to improve, whether everything gets solved on the first try, or it takes a while to sort it out. It's the same way I would argue that we want to be engaged with, my teenage kids when they were teenagers, right? You want to be in their life. You want to be part of the source that they go to when they have a problem that they need to fix. Sometimes we know the problem before they do. So I think an engaged patient is a patient who isn't opening the app because their doctor told them to open the health app. They're going to the app because it's answering questions that they have. They're going to the health system because it's a resource that works for them. So I think of patient engagement is actually not so much a goal, it's an outcome. In other words, if you're doing your job well, your patient's engaged. If you're not doing your job well, the patient's not engaged, you need to be doing something different.
Awesome. I love that. I picked out a couple things, relevance and knowing folks, right? Knowing what their needs are. And in some cases, you said before they even do. So we should get a little bit more into that. Next over to Sari Kaganoff.
Hey everyone, thanks for having me. I am the general manager of consulting at Rock Health. I'm probably the odd person out here as I'm not from a health system. Rock Health, for those of you who are not familiar, is a digital health focused company. We've been around since 2010 with three main parts to our business. We have a venture fund that invests in early stage digital health startups. We have a nonprofit arm that focuses on health equity. And then we have an advisory business, which does a lot of research on the digital health ecosystem and supports different companies in the space across the spectrum on their digital health strategy. So I think a lot of our activity as it relates to this may be coming from a different perspective than the rest of you, both looking at tracking startup activity as it relates to engagement. We also conduct consumer adoption surveys every year to understand how consumers are engaging with their health, and also work with a lot of enterprise players, not just providers, also payers and pharma and med tech and tech companies. So we have kind of a broader perspective. Given all of that, I would say I think of patient engagement really more as empowering and encouraging consumers to better understand, control, and participate in their care. So it's really about this, giving them the tools to do what they need to do. And so, probably a little bit separated out from how maybe the health system itself, although that could come into play as part of that set of tools.
Awesome. And, we're really looking forward to digging into your market perspective, Sari. So I'm so happy that you're here. And last, but certainly not least, Andy Chu, who I get the privilege of working with every day.
Thank you. My name is Andy Chu. I'm the SVP of Product and Engineering here at Providence Digital Innovation Group. So my team essentially have built some of our core capabilities in which including as of last year, we spun out DexCare. So that's the focus of my team. Specifically, as of late, we've been working on the identity and consumer engagement platform, which falls squarely into this topic. To me, engagement, I love the analogy of what Lee talked about, because I have two teenager kids myself. It is about not always there, but always will be there when someone needs you, and also anticipate their needs by looking at the telemetry of the data, their mood, what's going on in their lives, but it's hovering in the background. But they, as a patient or consumer, has the trust to come to you when there's a problem. And it's a trusted brand, it's a trusted source of information, something that they can always rely on. So to me, that is engagement in the healthcare setting and environment.
Awesome. Thank you all for your introduction, sort of opening comments. And it sounds like, we all agree that engagement is core to what a health system should be doing. But let's, sorry, from your perspective to what you see a lot of companies coming out with these days. But let's start with the end in mind. What do you all think, we're truly trying to solve for? Perhaps like what's the core reason for wanting to do engagement? Lee, you started out by saying it's an outcome, not the goal. But why would we desire for that? In addition to kind of folks coming to us when they have a problem, but what's the core value prop? Why would we do it? What are we solving for? Lee, let's start with you.
Yeah, it's a great set of questions. There's a lot to unpack inside there. I think the first thing we have to remember is the answer differs if you're in a fee-for-service versus a risk environment, right? So that's the first one. That's more from a business perspective. From an altruistic perspective, we want to improve health outcomes. Like that's why we're on the planet in these jobs, is to make health outcomes better for patients. And we know from a lot of research that a tremendous portion of the variability in outcomes is not based on what happens in the office or in the operating room or, in the emergency room. It's what happens after, outside. And that was what I was saying before. If patients are engaged in their health, they will adhere to the care plan. They will call with questions when the care plan deviates from their expectations, when they have what they perceive as a complication. If they can't afford the medicine because their insurance didn't cover it and it's $600 a month, instead of just not taking it or not filling it, or filling it and spending all that money when we could prescribe a generic alternative or one that happens to be covered by their health plan. So I think if we want to improve health outcomes, we have to abandon this idea that our responsibility stops at the four walls of the clinic, and it needs to extend into patients' lives. And so when we engage with patients, we stand a better chance of influencing those health outcomes. I like to think of the analogy of, we have a bow and arrow. You pull the arrow back and you aim with your other hand and you let go. And the minute you let go, the trajectory is set, right? That's what we do now. What we'd like to do is continue to sort of hold and guide that arrow for a bit longer, so it has a greater chance of hitting the target. So I think in a risk-based model, it's quite aligned with the financial, expectations of the organization, because the more you reduce events, the more favorable that is for you financially. The more the unexpected and costly events occur, the worse you perform. In the fee-for-service model, though, I think we really need to find ways to ensure that those incentives are well aligned, and think of it as a mechanism for keeping the available capacity open to new business and to tertiary referral if you're a complex academic or a not-for-profit health system. The backfill and better curating of your care mix is probably the way you win there. Never mind reputation and quality, but I think it really does. The boardroom is very swayed by the financial impact of these strategies, and it's hard to find the capital to fund some of this work on engagement if you're living in a purely fee-for-service world. I'm going to turn it back to you, Sarah.
Absolutely, Lee. And before I move on to another panelist, we got a question actually in the chat that I'm going to pose to you, which is that if we're being consumer centric, why should our definition of engagement be different in fee for service versus value based? I think you've talked about like the underlying incentives are certainly different. And the person asking the question says that seems like we're letting our incentives and structure dictate what engagement we're willing to invest in or support. Can you just go a little bit deeper and go ahead?
Yeah, I mean, yes, that's where we should be. And we should also probably be a single payer, health system if we want to achieve the gains in value that we can get through that, right? Value defined as Michael Porter does as quality over cost. There's no question that we should be aligned in that regard. We should be paying for prenatal care. We should be, funding Head Start. There's lots of things that pay off in the end. Part of the challenge is that the people who pay for the upfront interventions don't always save on the back end as a benefit from those prevented health outcomes, negative health outcomes. So I agree. I think from the design perspective, the patient experience should be very similar, maybe not identical, but very similar in those two environments. The reason I say very similar but not identical is that patients may choose to tailor their experiences differently. And in some settings, we may offer either sort of basic versus premium services. We may want to incentivize patients in risk contracts to take different care paths, different care journeys. And I don't think there's anything wrong with that, as long as in the end, you're achieving the best health outcomes you can for that patient based on all their social determinants of health, the limitations and resources of the health system, because we do practice in a world where constraints exist, and we have to make sure that our care plan, even if it has an ideal outcome associated with it, can be adhered to by the patient. Because if the patient can't adhere to it, doesn't matter how good the care plan is. And I think that's sort of where we are right now. We try to stuff everybody into one size fits all, and the result is it doesn't fit a lot of people, particularly patients with social determinants of health. And let's talk later in the hour about the equity lens and how that needs to be accommodated in any of this work we do, particularly around digital patient experience.
Great. Thanks.
Maybe I'll
Go
just
ahead.
jump
Sorry.
in there with one other thing. I think that, there's the ideal world of who owns what, et cetera, but thinking of the reality of the fact that there are other players in the ecosystem besides the health system, right? There's the payer, there's other service providers. And so in a way, saying, fee for service is a little bit different is actually not necessarily a bad thing, because you as a health system need to recognize that you need to work with those other parties, whether it be the payer or other service providers. And so in that construct, just being aware of the other players, making the handoff seamless may be the right thing to do, rather than trying to own everything yourself in that situation, even beyond just the financial implications.
I think that's a fantastic point, and I hope we'll get into that. The ecosystem that surrounds the patient. We are not the only player, and in many ways, we're disintermediated already by Google search and what your friend says and your neighbor told you about their experience. And so I think understanding how to create a digital patient experience or a patient engagement experience that allows patients to have the same kind of freedom and confidence that they understand what they're being asked to evaluate, consume, engage with, is a huge piece of this that I don't think we've tackled very well yet.
Yeah, I think just add on to that, right? So if you look at the ecosystem, and we're going to get into a little bit more, is there are increasingly more and more companies, and VC has invested billions of dollars. This is last 2 years alone, and those are going direct to consumer and going directly to employer. So I think it's very important for health system to recognize that, and what can you do to start engaging in that regards. Because it's no longer people are going over the top directly, a term that you utilize in other industries, but health system hasn't really heard of these terms, because historically, effectively your engagement is your EMR, or the limited capabilities that you're providing on your .org site or .com site, and that's we have to definitely move beyond that and really think about this more holistic approach.
Yeah, Andy, that's a great segue into actually another question that we got, which would like you to comment on in just a moment. But so the question is, it seems like we're still talking about patients rather than people, and we spend most of our time not being patients, which is especially relevant in the context of what you just said, which is that often we equate engagement with the EMR, and we need to kind of decouple those two things. Most people don't really care about health as an outcome, except when we're sick. Our care journey needs to fit within our life circumstances rather than the other way around. And it's really about resonance and relevance. It's about health. It's about life, your more broader life. Can you comment on that in the context of what you just said with respect to decoupling the EMR from engagement experience, and what does that actually mean? And like, how does that relate to work that you're doing today?
Yeah, I think one of the key challenges, I think for most health system, if you span out back to last 10 years, EMR is great. It's built for workflow, for clinicians, for decision workflow. However, it was not built with the consumer-centric in mind. And most health systems, as a result, they inherited the identity. Essentially, the patient identity is equivalent to the EMR, which is a really tough spot to be. Per the point I just made, increasingly you're seeing more and more upstarts direct competing with health system, and there are companies going directly to consumer employers. So I think you start out with, at least at the digital standpoint, you need to figure it out how you are going to sort of extract the identity, who the consumer or the patient is. Another analogy is like, if you look at what Starbucks has done last 10 plus years with the wallet, or what Amazon's doing, I mean, you can't really build a great digital engagement platform without knowing the identity of the consumer. And that's like the first cornerstone you have to build. And from there, then you can start talking about how you can, in a private way and with governing body and policies, to start pulling the right data so you can effectively make better decisions around how you can start, quote unquote, engaging with the consumer. And that engagement could simply be making it easier for the patient to book an appointment with the right physicians, looking at bills. These are problems that, again, have solved in other industries, but in healthcare, it's just very, very painful for our patients. So I think we have to go back to the basics and start looking at and identifying what are the key building blocks we need to figure it out. And I would argue that, identity is the first thing that you have to sort out. And then you can talk about profile, you can talk about data, and then you have to put in the right infrastructure in place to do that.
Hey, Sarah, can I just jump? I just want to jump on one thing that Andy alluded to and that you did in that comment. I don't think it's just a digital issue. I think we do a terrible job of treating patients like people in person. Our systems, we talk in medical terms, we're hard to access. We have big things like waiting rooms and parking lots that, no patient would want a parking lot or a waiting room. They would like to come in, be seen, and leave. So I think that, we want to start treating people like people in every aspect of our work. The second thing is, and Andy just alluded to it, most of this consumerism experience is built on pretty intensive tracking technology that leverages a lot of information about you and raises, I think, for some patients, concerns about Big Brother. They don't want personalized ads about colonoscopy after they go to your website to search about colon cancer. So I've been starting to think about this concept of not older brother, but Big Brother, right? We want older brother, not Big Brother, right? We want the person who's going to look out for you, who's going to take care of you and protect you. So it's going to collect enough information about you to make sure you're safe and get what you need, but not that they're staring over your shoulder and trying to control your life.
Great. I love that. Older brother, not Big Brother. It's got more of like we're here to help you as opposed to we're your overlord, right? There's a very different sort of lens that you would apply to how you would serve folks with that in mind. Nick, I'm going to go over to you and kind of ask you a double question. One is, what are you solving for as it relates to engagement? And then to build on that, if you could comment on this, it's been obviously a challenging year for health systems, and we need to create necessary, connected, meaningful, scalable consumer experiences to reach our goals. There's a lot happening out there. There's tons of point solutions, platforms are consolidating, there's just a ton of applications. And there's sort of this general approach to how are you tackling this, right? How are you creating, what are you specifically doing? And then I'll go around and ask others, but with your end goals in mind, what are you trying to accomplish? How are you specifically tackling it at Baylor Scott and White to bring those connected experiences together? And what do you think are let's just start there.
Yes, Sarah, good question. Perhaps three things I would say from where we sit, how we view the world. One is we're trying very hard to reorient ourselves around consumer journeys and moments in those journeys. And we're trying to pick which ones we want to be world-class at. And picking is really hard for health systems, right? The answer is everything, always, right? So first, reorientation to the consumer and picking certain journeys, certain moments that matter, and trying to be world-class. So that's a way for us to frankly focus. And by the way, if we're picking a journey that, there's a lot of entrepreneurs or private equity, we do want to partner with them. Like, there's no point in building something. There is an ecosystem out there that could benefit us tremendously. So having that mindset's important to us versus ain't invented here mindset. So we're picking our journeys and we're looking at the market and trying to partner with those we can. That's a big part of who we are, number one. Number two, I think, Sarah, to answer your question, it's if you ask consumers and if you're really consumer centric, not just say it on PowerPoint slides because it makes us feel good about ourselves, the consumers tell you to your face what they want, and they're not shy. They slap you around pretty easily with their surveys, and where you're terrible, they tell you. So you just have to have the audacity to ask and listen. It's not rocket science. It's a very simple question, and they tell you where we're broken. They'll tell you our payment's broken. They'll tell you where the experience doesn't matter. And when we read the consumers to us, it falls into three broad buckets. They want simplification. Health systems are complicated for them. They want us to simplify, whatever that is. Simplification comes in different terms. They want, I think, orchestration, which is some of the stuff Lee spoke about. There are services that they need that we don't provide, right? So what do we do, right? We have to serve the customer. What do we do, and how do you go there? And finally, I think ultimately what will win out, and this is a personal opinion, not the opinion of my sponsor or the employee, my employee, but ultimately I think what will win out is personalization. We know you strategy, clinically and behaviorally. If you know your customers and you're able to be proactive and serve their needs on their terms, because here's the blunt reality for health systems. There's 50 states in our country, and every state has 5 to 6 cities, and there's 3 to 4 health systems in each one of those cities. So no matter what we believe about ourselves, we're usually not that unique. So everything we do, others do, right? So what would, if you think about what will differentiate us, it's really getting to know the customer and engaging in a way that's personal to them. And healthcare is more personal than anything in the history of humankind. So that's the second thing we're thinking about. First is consumer journey. Second is sort of simplify, orchestrate, and personalize. And finally, Sarah, what I would say is one of our things we're trying to figure out within our system and our mindset is there's some things we have to know our own limitations. Like Lee said something that I'm very passionate about, and I read somewhere recently that said your boss will have a bigger impact on your health than your primary care physician. So we have to know, the role of the health system, the role of the communities, the role. So I think we have to understand irrelevant of what reimbursement model, we have to know, what we can impact about health and what we can't. And sometimes I think we don't understand our limitations. So sometimes we just have to be humble about it. And you don't get a lot of Christmas cards when you say those things in health systems, but I think it requires some humility internally. But that's sort of how we're approaching things, Sarah.
That's great. I mean, I think you said it. You kind of summarized it well at the end, like what we can and can't impact, what we can and can't own, and ask your consumers and around what they want: simplification, orchestration, personalization. So Andy, I'll turn it to you really quickly. Are you all, like, how do you see it? Are you trying to build everything? Do you think you need to secure it all yourselves, or are you also taking this sort of broader approach? You did reference an ecosystem, so tell me a little bit more about how you're thinking about the ecosystem. And someone had asked in the chat as well, would you say that an ecosystem is consistent with or is synonymous with a marketplace, or do you need something different from that? Is it more just about connecting to all of the different things that are out there that impact a given individual, or is there something kind of more nuanced there?
Yep. Yeah, to me, ecosystem is a little bit different than a marketplace. Marketplace, you just go there and shop a bunch of stuff. Ecosystem, I mean, you're working, they're partners, right? I think, payer is a partner. There are other health system is a partner. There are other upstart companies specifically focusing on, XYZ health outcome is a partner. Data providers, big tech, I think is beyond a marketplace. Right. So I think the way we think about it is from a patient standpoint. I'd like to go back to the identity. It's hard to work within first of all, we're not going to build everything ourselves. It's just not possible. And to Nick's point, there are a lot of investments in this space. You sort of have to pick and choose what are the core things that you need to make it efficient, and what are some of the things that you need to can partner. But I think there are a few things as health system that we sort of need to own or evolve, I would say. We have to really evolve from just a EMR-centric world to a more consumer-centric world. Like I mentioned before, EMR is really designed for within the operations of a health system, but then if you want to engage with consumer, it can be challenging. And I think, as I mentioned, from booking appointments to look at bills, those are very, very simple tasks, one would imagine, but yet we all know it's a very painful process for all of our patients. So I think we just have to figure it out just at the simplest term. Back to Nick, he just dropped off, looks like, that your consumer is going to tell you what their needs and wants are, what are the biggest pain points, and identifying those journeys and trying to figure it out. What can you do operationally? What can you do from a technology standpoint, be it leveraging your existing resources or go partner with third parties are important. Yes, barring all the other complexity around bringing a vendor into a health system, that's a whole nightmare itself. Just park that one aside. But I think those are the things that you have to decide to really focusing on prioritizing what type of problems that you're trying to solve for. And at the end of the day, you sort of have to take a maybe even 50, 60%, 40% rules, and because you're not going to solve for every use case either, but really identifying the core consumer journey and what are the common pain points, really cutting across majority operations and figuring out what are the key common technology building blocks that you need to put in place. And then you go from there. So that's how I would think about that, and that's how, from an approach standpoint, how we do development.
Hey, Sarah, can I tee off on something that Andy just alluded to, which I think is a really, it sort of fuses some comments that Sari and Nick also made. If we're going to be effective in this journey, we're going to need to offer things that we don't typically offer as health services, and coordination of care and logistics and supply around things that might be needed in the home. As we shift more care to the home, we have more logistical support requirements. So part of the problem about being baked inside the EHR is it's very limiting in terms of how you can reconstruct the patient's experience of the EHR, but it also makes it almost impossible to offer them other experiences, because some of these things you're offering have nothing to do with the EHR or the services that are contained within that. There's a lovely example, when HIV treatment became available and antiviral therapy was first introduced in Africa. It was completely ineffective. And it was ineffective because if you're totally malnourished, the HIV drugs don't work. So the clinics started growing like fruit and vegetables, and basically they would provide patients with food and medicine, and then patients got better. And I feel like there's a really important kind of learning in there, which is we have to do more than just provide prescriptions and, clinics visits and blood pressure cuffs and things like that. We need to figure out how to engage patients based on their needs. And I think it gets back to that question about what is patient engagement. It's I have needs. I may not know all the things that are part of that need. I may know I want a loaf of bread. I don't know the recipe. I don't know the ingredients, but I know I want a loaf of bread. Or I might actually know some of the ingredients. Our job is to take that request in, digest it into a series of requirements, and then try to deliver on those requirements in a way that is most easily digestible by the patient. And so we get into this problem where the EHR is very constraining because it processes things very much as transactions and encounters. But we also have the problem of we have third-party members of this ecosystem, but so many of them are trying to also sort of be all things to all people. So you get huge overlaps in capability, along with things you've already invested in as core capability. Everybody puts a video client in what they offer now, but you already have a video client, or everybody wants to pack a little CRM, or everybody wants to do a little identity management. And so I think what I'm hoping is if we can drive these markets to maturity, things will be more modularized. You can consume the components you need and rely on interoperability solutions to knit the experience together. But I have to say, it takes a lot to orchestrate a smooth experience. It's not trivial, and it's highly dynamic. It's a very complex biological system because patient needs are not predictable, and patients don't come with the same set of capabilities each time. So I think that's where we have a lot to learn, and where third-party partnerships could be extremely valuable. We're not great at orchestration. We're really good at diagnosis and treatment of complex conditions. When things are rote and subject to automation, I think we've generally thought of those as down market problems that we don't like to tackle. So we have to find the right partners who are not viewed as disintermediating us from care, but actually as providing the highest value solution at each stage of care, bound within this universe of interoperability where the data isn't lost.
That's a beautiful segue, Lee, into let's get a little specific. So I know Andy, Lee, and Nick, you each are building something to achieve these things. We've got over 300 folks here who I think would benefit from knowing, well, specifically, how are you bringing some of these principles to life? And I think there are some slightly different approaches here. So Andy, let's start with you. What is your team developing, and what's your vision around sort of identity-driven engagement? Why don't you start us off, and let's keep it to a couple minutes each, and then we'll kind of get into some additional details.
Yeah, absolutely. So I think I alluded to it a little bit earlier. I think one of the key investment that we have put in place over the last couple of years is the identity solution. So essentially, if you're a Providence patient, your identity is no longer a EHR specific identity. So it's a Providence identity. Now, this allows effectively to pull in third-party applications or third-party services offering that we can bring to bear. Second, like I mentioned, a lot of health system, financially is constrained. So we build a lot of the, in our case, we're Epic Shop, we build a lot of the EMR feature is probably not feasible for us. So essentially we build an environment sitting on top of the EHR, and we look at data and see what are the specific things that consumer need and wants and highly engaged, and pull those things out so that consumer and patient can discover and interact and engage more easily. Then effectively reduce the barrier and reduce the frustration for consumer, and as they are engaging with us from a digital standpoint. And then thirdly, we're putting in place sort of the guardrail as well as the data infrastructure to start pulling in, again, the third-party applications. And that guardrail is important, right? Because there's so much sensitivity related to the information and data, what cannot share, and how you engage with the patient, so you don't look like a big brother, but an older brother or parent. I actually like the parent analogy better. So to teenagers. So I think those are the pieces that we're putting in place. So I'll hand it over to other panelists.
Great. So if I were to summarize, Andy, I heard identity, kind of a single place where things can get surfaced and orchestrated, and then putting in guardrails around how those things get orchestrated to a given individual. And of course, all of this is sort of personalized to them based on this identity layer that you have.
Absolutely.
Nick, I know you all have taken a bit of a different approach and have gone a lot deeper on the sort of EMR services side of things, but can you tell us a little bit about specifically what you all have built from an engagement standpoint?
Yeah, Sarah, and I was very heavily influenced by things that are not from healthcare. So when I first got my role, I sort of traveled the country and went everywhere that was not healthcare on how this was done. And so I was influenced by that. So fundamentally, both the logical, functional, and technical architecture for us falls into three broad swim lanes. Systems of record, obviously. And systems of records are not just EHRs. We have about 14 of those: health plan tools, wellness, different virtuals. So there's different systems of records. And they're very helpful. I'm a very, probably one of the few people that love our systems of records and Epic. I've been in healthcare before we had systems of records. So I've seen the before picture, and I'll argue that the after picture is better, perhaps not already there. It's perhaps not 10% body fat, but it's much better. The BMI is much better than what it used to be a decade ago. So systems of records is one layer for us. And on the other bookend is systems of engagement. And it's the things we talked about. We are continuing to try to use consumer journeys to simplify. We have a very deep integration. We've decided to own the consumer journey. So if you go to an American Airlines app or a JP Morgan banking, they're not displaying, SAP, right? Or Saber's mainframe in American's case. So they've built systems of engagement, because once again, if you fast forward healthcare 10 years from now, do you believe you will provide all the services yourself, or do you believe you'll participate in an ecosystem where others will be providing services? And if you believe the latter, then you would obviously have to, so essentially think about systems of engagement. And then in the middle, what we're focused on now is systems of intelligence, which really is, I think this is the first innings for healthcare. But I think in the next 10 years, I think I forget Lee or sorry mentioned this, but there is a really good probability that we will start predicting diseases. This is not prediction. I think pretty good probability will predict diseases, whether it's using genetics information or diagnostic information or whatever those things are. And once you predict them, that's, prediction's pretty easy for a lot of the nerdy AI folks these days. That's not a difficult sport anymore. But what's difficult is the clinical sport. Is once you predict, what do you prescribe? And I think the clinicians will sort of drive that to, in the next 10 years. So we're excited about building those three layers. Once again, systems of records, systems of engagement that face our users, and we own that completely. So it's our journeys. If you see it, it's our brand, our logo, our customers, our experience. It's all API economy, all the things you would expect from non-healthcare stuff. And there's systems of intelligence that today, my biggest criticism of healthcare digital, including myself, is most everything we do is static. It's pretty dumb and static. And I think for it to be dynamic, I think you would have to build systems of intelligence, which is sort of, I think it will keep us busy for the next 2 to 3 years to continue to do that. It's basic things today, like gaps in care and, basic consumer nudging, all this sort of third grade material. But healthcare data will have the most impact in our industry, I believe, in the next 10 years.
Awesome. Thank you, Nick. And then over to you, Lee. How is MGB thinking about this, and what are the specific things that you're putting in place?
I don't think it's fair that I have to go third after these two luminaries have kind of laid out all the highlights. So I guess I would say, let me just sort of start with some of our core principles. Is really, like I said before, trying to treat patients like people. Really thinking about, and what do they want? And we think what they want is they want to be known. And they want us to not just care for them, but care about them. They want to know that we actually care, that we're not just delivering a service and, taking a margin and, going on to the next person. I think we definitely agree with Andy. You've got to pull identity management out of the EMR and manage it in a different place. And we have reconceptualized the digital front door, which is really what we're focusing on, as something that's actually quite dynamic. It's the intersection between the digital channels I have available and what I know about your identity in that moment, in that context. So if you're an anonymous user searching my, kind of web properties, you'll get lots of information, but there's very little you'll be able to do. You might be able to look at appointment availability, but you won't be able to book it. The minute you authenticate to some degree, either through federation of another sign-on, like your Apple ID or your Google account, we'll let you consume a little bit more. Till we get to the point where we have complete identity validation and identity proofing. We know that Andy Chu is the real Andy Chu and that it's him right now. Then we'll let you do lots of things, update your records, download your information, share information about your behavioral health issues, sensitive information. So we really need to completely rethink identity management, like the way we think about provider data master. Now we need patient data master. We need like referring provider data master. So we really have to embrace that concept that the data and the knowledge about the patient and about the relationships that the patient has to objects, to services, to needs, to social determinants is really vital. And we're implementing a big CRM component to this. That's what we believe is kind of the future of the base technology to enable this. But unlike most of what I am exposed to when I talk about CRM from the vendor marketplace, which is, okay, new patient acquisition, we can increase the new patient by X and these will convert, and sales leads, conversions. For us, it's actually more about adherence conversion. Can I do targeted marketing to my existing patients where I know I have care gaps and leverage some of that intelligence that Nick was referring to as sort of next best action? If I know A, B, C, D, E, F, and G about Nick, and I know he hasn't had his screening colonoscopy for 5 years now, and I've sent him emails and I've called him, what is the right next step to do rather than yet another phone call or yet another email? Is it to call his proxy, his next of kin, his medical, emergency contact, whatever? What's the way that's going to get Nick motivated to actually adhere to the care plan? So that, I think, for us is where we want to go. But we have to recognize we can't get too far out ahead of where our providers are. None of this works if the providers aren't there. So a big part of this journey is actually, number one, convincing providers that we're not just shifting work onto them. We're not making patient journey easier at expense of provider. We're going to use automation, smart routing. We're going to reconfigure skill sets so contact center can handle a lot of stuff that's currently going to provider office, to create headroom and space for providers to start thinking about this engagement in a new way, because it is different for providers. And we need for them to engage with the patients, but we also need the patients to engage with their own health. Because if we don't have that partnership, I just don't think that we're gonna get there. So the big challenge is going to be, all this information's out there. It's all flying around, or data, I should say. How do we trap the right data, make the right investments to yield real value from that information? Because you could spend a lot of money on your digital front door or your engagement experience and have it not translate into value. And that's challenging too, because there's a lot of places to spend money right now. So how do you get that right? That's really what our focus is, trying to figure that out.
Awesome. And oh, go ahead. Sorry, I was actually going to go over to you and just say, let's come back to the provider engagement question in just a moment. But sorry, and you may want to have a follow-on point too. But also, if you could comment on, you've heard how these health systems are viewing the topic and what they're building. How do you see that fitting with respect to the broader market and all the other stuff that's going on? There's a lot being built. There's some platforms coming together, like through some consolidation activity that's being funded by big funds, venture funds, and PE. So can you comment on that? Like, how does this line up with what's happening in the broader market from your perspective?
That's a great question. And I think what's interesting is each of you touched on pieces of recognition that you aren't the only player, and that there's other people to work with, whether it be partners or handoff points or other things. One of the big themes that we see is a huge rise in the investment going into what we call sort of infrastructure and interoperability players. In fact, in 2021, we saw around $2.2 billion going into companies in that space. They're not all targeting health systems, but they are kind of all focused on this idea of either modularization of plug-in pieces or connectivity of data across different stakeholders. And if you look at prior years, 2020 was only around 730 million into that space, and it tails off pretty quickly after that. So it's really an obvious need that everyone is suddenly recognizing, wait a minute, if we're all creating experiences for consumers or for patients, and we want to connect up between them, we're going to have to do that. So I think, on the one hand, yes, there's a recognition and there's more tools growing for that purpose. I think what we have not yet seen is how it's all going to shake out, right? So we see, on the one hand, a lot of companies focusing on this infrastructure and interoperability, passing things back and forth. On the other hand, we do see a lot more consolidation of services, like you were mentioning, Sarah, around, can I just get all these things in one place instead of going to different places? I sort of think of it as, when you look at analogies of the outside world, and someone mentioned airlines and banking before, there's different ways that the connectivity has worked in those different industries, right? Obviously in tech, we have App Store and people can download different apps on that, but there's a certain standard. In the airline industry, you have the underlying infrastructure that enables kayaks to see all the flights, except Southwest. In finance, you have things like Plaid and Stripe and other things. So I think we're not there yet where we have a standard in healthcare, but we definitely have multiple standards approaching at the same time. Some that are more for transferring data, some are more for modularization of pieces, and some that are more platforms to plug into. I do think thinking really carefully about what do you need to offer as a health system, what do you need to plug into from the external environment, and where do you say, this is not my place, is important, because that challenge of overlapping services by everyone is just essentially an economic waste and just even more confusing for patients. So finding that right balance is key. But we definitely do see a lot of increasing activity in this space.
Sorry, I'm going to follow up with another question for you. You mentioned there's this sort of modularization piece. There's a lot happening around infrastructure and interoperability. There's platforms that people plug into. Do you think that we're going to, and you mentioned that in other industries, maybe not a single standard, but some standard is emerging, right? Mm-hmm. And it becomes what the vast majority of the industry builds upon. Do you think that's possible? I know we're very early in the maturity curve, but do you think that's even possible? Are we going to get to that point, or are we going to have sort of this very fragmented environment and a more distributed environment where just pieces just talk to each other, but they don't plug into a standard? Yeah. How do you think that's going to come out?
Yeah, so I don't actually think we're going to have a clear as standard as some other industries, because I do think, as we all like to say, healthcare is more complex and there's just so many different types of players trying to offer different services. I think we'll have pockets and sort of areas where there is a standard, or I hope we'll have, areas where, okay, for certain activities or for certain things, there is a standard way and data will speak to each other and those kinds of things. But I still think we'll have multiple ecosystems that live, in different shapes and forms. I mean, even just looking at how care is delivered, just this week with Rite Aid announcing the partnership with Homeward, delivering care in a completely different way that is not the same as how a health system would deliver care, right? And so I think it'll be really hard for all of that to live on one standard, because there's just so many different angles and players and needs. But that said, I hope that over the next few years, we do come to a place where at least some of this stuff is standardized, modularized, data speaks to each other, and we can more easily pass things back and forth.
Got it. Thank you. We only have a few more minutes, so I just want to come back to one thing that we talked about as it relates to provider engagement. And Lee, you started to touch on this a little bit, but can you talk about how, like, some of the provider considerations as you shape your consumer experiences, just get a little bit deeper? And then Andy, I'll ask you to kind of finish off that section with just your thoughts on self-service and how that supports it. But Lee, first over to you, if you could comment a little bit further.
Yeah, I mean, I think this is a different story now than it was 2 or 3 years ago. I mean, COVID has really changed the playing field. We have a lot of providers leaving to go either out of healthcare altogether or to go into, sort of paraprofessional roles where they're not doing direct clinical service. We have people who feel very abused by the electronic health record and how it has forced them to change their workflow and assume many tasks that many people would feel are more clerical in nature, and really put a tremendous amount of emphasis on, like, encounter closure, billing, administrative. A lot of things that previously were assisted by other people are now more squarely on the backs of providers. So I think that's a challenge. And I think there's also a little bit of a fear of, I don't want more information. Like, I don't want to know more about my patient. I don't want to be responsible for more about our patient. We had a tremendous challenge even getting standardized questionnaires like the PHQ-2 or PHQ-9 that look for, depression and suicidality screening, because they didn't want that in a record that they were responsible for, but didn't have actually the ability to refer to psychiatry for care management or even in a crisis. So I think there's definitely a feeling of, I'm overwhelmed, and what exactly are you asking of me? And are you now going to put 15 minutes of questionnaires in front of my visit? So if the patient arrives on time, they get to me 15 minutes late because they're still doing their e-check-in and questionnaires and, all these other things. The other thing I worry about with my providers is that we have a very strong commitment called United Against Racism, and really looking at digital health equity and health equity at large. And a lot of concerns that digital solutions, while they work really well for some group of patients, disenfranchise further another group of patients. And so that's another really challenging tightrope to walk, which is, how do you do digital enablement that raises all boats, or at least doesn't depress other boats at the same time? So I think we have to be really thoughtful, and we need to do some provider-centric design as well as patient-centric design. A lot of the design, I would say, from the last 10 years, which has brought tremendous benefit, has really been like EHR-centric design. How do we get as much as we can connected in the EHR through the EHR? And that has been tremendously successful in bringing data to make it available, but without the intelligence that Nick was referring to, so that I get smart information, not just reams and reams of data that I don't know what to do with.
One thing to note, though, is that from the clinical perspective, our research has shown that patients often are more willing to adopt digital solutions when their provider recommends it. So I think that it's not only important to get the providers on board for themselves, but also to enable a lot of this clinical care, especially things that are more predictive or kind of disease management in nature, to be more comfortably accepted by patients as well.
Yes, absolutely, Sarah, which is why provider engagement is critical. Because if you don't have provider engagement, you don't have patient engagement. I have a very heretical member of our health leadership team that says, don't focus on patient experience, focus on provider experience. Because if you have a great provider experience, you'll have a great patient experience. If you have a terrible provider experience, nothing in the world will save the patient experience. It's a little bit heretical, but I think it makes a point.
Yep.
Yeah, and I know we're almost out of time, but Andy, why don't you go ahead and make the closing comment? Go ahead.
Yeah, I think that gets to the automation. I think Lee touched upon it. EHR, while has been great, for essentially patient can start from their point of view just texting their providers, but from providers' point of view, it's caused burnout and all kinds of issues. We actually have done a lot of analysis on that using machine model and other things. And if you look at it, to Lee's point, there are tons of questions and answers are non-clinical related. And all those things are ripe for machine, chatbot, and the like to help automate self-service for patients. And most consumers are comfortable, to Sari's point, in adopting those type of technologies. So we are looking at ways to actually automate a lot of those things for patient. Therefore, but we actually look from the provider point of view in that case, and solving to see what are the pain points that they have, and how do we bridge the gap between the consumer side and the provider side. And we say provider is not just the provider themselves, but also the entire care teams, right? So you have MAs, you have RNs, you have people that are actually also getting burned out as well. So we're looking at it more holistically for the entire care team and see what we can actually automate. And we're starting to do experiments on that front.
That's awesome. And I mean, you summarized it well. Fundamentally bringing the ends of the value chain together and doing it through some of these mechanisms around self-service and automation, and viewing both ends of the value chain as our users and our customers. So with that, thank you all. Thank you for staying a couple minutes over. Thank you to the folks who joined us today and the participants. I had a great time. I learned a lot from all of you and really appreciate you joining today. Thank you so much.
Yeah.
Thank you.
Thank you. Bye-bye.
Thank you to Sarah and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.